Welcome to Big Butts, No Lies. I'm Mavi, your go-to guide for everything plastic surgery. With 18 years in the industry working alongside top board-certified plastic surgeons, I know what really goes down: the good, the bad, and the botched. Now I work for you, bringing you real, unbiased info to help you make the best choices for your dream look. Whether you're going for subtle enhancements or a full-on transformation, I'm here to give you the facts, the tips, and the confidence to navigate your surgery journey. Let's get into it. Should be fun. Hey guys, do I have the show for you today? As promised, I am bringing you plastic surgeons from across the country, from every angle, every corner. I'm bringing them to you. And today, I'm super excited to have Dr. Eric Anderson out of Chicago. And you guys are going to love him. We're going to talk about something a little different, which is something he was talking to me about: the Midwest aesthetic.
Yes, thank you so much for having me. I'm really excited to be here and talk about this. So this is something that's been going on for quite some time. And this all has to do with kind of being from the Midwest and being raised in the Midwest and just loving the Midwest. So I'll be here forever for my whole life. And of course, I'm a plastic surgeon. My focus and my heart is in breast surgery and body contouring. And so this is something that myself and my partners have noticed kind of through training and fellowship and now our practices. But the Midwest aesthetic is something really, really important. And what is that? I think it's really simple. But basically, it's that being from the Midwest is classically like a very conservative, kind of a refined, subtle thing. You know, no one's very flashy here. We don't have like the super fancy New York City vibe or the super chill West Coast vibe or like the crazy bodies from Miami. That we're kind of somewhere in the middle of that. So what does that leave us? That I think that really imparts on us a sense of subtlety, refinement, kind of that quiet luxury, and that imparts and kind of bleeds into our results and what our patients want to see in their surgery and how we operate as surgeons as well. So I think it's a really, really cool concept. I think it's something that's been happening for a while, but maybe no one's put a label on it.
Yeah, I think you're actually right. It's probably been happening for quite some time, and nobody's really, well, at least nobody's brought it up to me about that it's the Midwest aesthetic. And it kind of sounds like what they're calling the Pilates body or the Pilates breast, where it's a little more toned down, not as noticeable. So if somebody comes to you and they're from the Midwest and they're like, I already know what they're saying. They're saying, I don't want people to be able to tell. I want it to be super subtle. Like, I don't want to look overdone. I want to look super natural. So what is that to you? What do you do in that case for that patient?
I mean, that's every single one of my patients. And I think that's rooted in kind of how we grew up and how, you know, our childhood through our adult life and things like that. So, you know, people obviously want to improve themselves. That's will be around forever. But the way people think about it here is a little bit different. You know, we're not raised to be flashy people. We're raised to be pretty conservative. You know, family values are certainly important. Not to say that other cities don't also hold importance there as well. But yeah, people want subtle results. People want those refined results. People want that. Like they'll come into me and they say, "Oh, I want a breast dog," and it'll be a young lady too, and they'll be like, "I want that factor where I'm out at the beach, I'm out at the pool, and someone looks at them and they're like, did they have a breast? Did they? Maybe they did. Maybe they did. You know, there's that question factor that kind of keeps them guessing a little bit. So that's like all of my patients, whether it's breast surgery or liposuction, body contouring, they want that kind of guessing factor.
I love it. Keep them guessing. They don't
Exactly.
have to know. They don't have to know what you're up to.
Exactly.
So when you're looking at a breast, for example, let's talk about breast. How do you decide, right, for a patient who's looking for a breast augmentation, maybe, what would be considered not as noticeable, right? So for our listeners who don't know, usually when you come in for a consultation with your surgeon, you're going to tell him what you're looking for. And he or she is going to help guide you towards the appropriate size implant or procedure. Sometimes it's not an implant, sometimes it's fat grafting or
Exactly.
a
Or a
breast lift.
lift.
Yeah, exactly. So
Yep.
how does that process go for you?
So this is a fantastic question. So what I start with is the patient goals and what the patient's aesthetic is and what they're looking for. That's one of the most important places to start with your plastic surgeon, because if your plastic surgeon doesn't know you and doesn't understand what you're looking for, you've already lost. Like you already because every patient is unique and is individual and has different aesthetic goals and wants and as a patient, you have an idea in your brain of how you want to look. And so it's my job to tease that idea out and make that happen, or tell you if that's even possible. To start, we'll start with breast augmentation. So the most important measurement is the breast diameter. So that's the footprint of the breast. And I think a lot of plastic surgeons would tell you that same exact answer. The breast diameter is the most important measurement. So that's where we start. And the worst thing I can do is give you an implant that's wider than your breast footprint. That makes you look heavier, that makes you look wider. That's doing you a disservice. So I never do that. So that kind of gives me a size range to go to. Like that gives us a fence, kind of an upper limit and a lower limit for an implant. And then based on your aesthetic goals and that look that you're thinking about, then we talk about profile of the implant. So if you're looking for that more conservative, refined look, maybe a moderate profile is something we'd lean toward. And if you want a little bit more upper pole fullness, then maybe we go to a full profile or extra full profile.
So for our listeners, what he's talking about on profiles is when you put that implant flat on your chest, right? The profile is what it's going to look like from the side. So sideways, how far off your chest is it going to be? And sometimes the implant number, which is, I was just talking about this with Darlene, who's a patient coordinator, and we were talking about how patients get stuck on the number. They're like, oh, like I want this specific number because I've looked at thousands of before and after pictures, and this is the number that I like the most. But in reality, maybe that size would look too small on them because of that breast diameter, right?
That's such a good point, because I just told my patient yesterday, I was like, don't think about numbers. Throw the numbers out and don't even worry about that, because based on her frame and her body, a 200 cc implant on her would look like nothing on a different patient, someone with a bigger chest or a wider frame. So that's such an important point that you made. Throw the number out. It doesn't matter at all. Everything is so unique and so customized based on your body and your shape and your breast footprint. And that's something that's really near and dear to my heart, is like the customization of selecting the implant. So you can have the best surgeon in the world, and if that surgeon doesn't pick the right implant, your result is terrible. So it really does take a great surgeon, an experienced surgeon, and customized implant selection.
Absolutely. So one of my questions that I have for you is so funny, because I want to know if this happens to you, where you have a patient who's like, I want to look natural. And then they show you a picture and you're like, does this look natural to you?
That ain't natural. Yeah. Every once in a while that happens. And it's a great opportunity for us as providers to educate and say, we can do that for you. Absolutely. But, this is, and then you kind of guide them in that direction. You say, that's not the most natural breast I've ever seen. And if that's your aesthetic, if that's the look that you're going for sure, we can help you do that. But, there's a huge educational component for that.
Absolutely. So with this with this coined term of the Midwest aesthetic, are you doing a lot of internal bras and fat grafting too?
That's a good question. So fat grafting, yeah, fat grafting is a great way to augment and kind of enhance results for sure. I would say I'm probably doing less internal bras because the implants aren't as big. So usually, if a smaller lady wants a bigger size implant, I would push them to get a not push them recommend for them to get an internal bra to really support that implant because they have such a small frame. But like I said, I'm not putting in a lot of really big implants anymore.
So what let's this is so interesting to me. What is your range? Like what implant range are you using the most of?
I mean, just this week, I put in 4 sets of implants, and the smallest implant I used this week was 175, and,
Wow.
and the largest implant I used was, I think, 350 or 375, something like that. And so that's kind of on the smaller side this week. Last week I used one that was like 485. So that's the biggest one I've used in a couple weeks for sure. So 175 to 450, 485.
Yeah, that's a really good range. I always like to talk about the different ranges and the different numbers, just information for our listeners who are maybe considering a breast augmentation and they have gone to consultation and maybe somebody told them, which happens all the time, this is the smallest size I'll give you. And in reality, maybe it's not the smallest size that's available. They just need to find a surgeon who aligns with that aesthetic.
Absolutely. I think it's so important to make sure your surgeon understands your aesthetic, and that relationship between patient and surgeon is so important. I can't stand when I see a patient that comes to me and says like a surgeon did not spend enough time with them. That is the most important thing. If I don't know my patients, I'm doing them a disservice. That's what I love about what I do. I get to meet everybody and form an awesome relationship with my patients. So, and that's really, really important and kind of essential to the best result.
And so I'm sure being in practice, you've seen over the last, I don't know, 10 years, this shift of the difference between a practice and a surgeon that really values the relationship with the patient versus the clinics that are more numbers driven and high quantity of patients versus the quality of the care that the patients are receiving. So I'd love for you to give me your insight on that.
I think those are absolutely directly correlated. So the more time you spend with your patient, the better quality you're going to have. And that's from a provider standpoint and a patient standpoint. So one of the things I love, I mean, obviously we're plastic surgeons. We do cosmetic aesthetic surgery. Insurance is not involved. So we're not trying to churn like as many insurance visits through the day. So I book a consult for an hour. I spend 45 minutes to an hour with that patient. I get to know them. I want to know what their aesthetic is, what they're thinking, what they're feeling. I always have patients send me goal pictures because I want to know, like you said, what they think natural is, because it's not always my definition of natural. So I think that's really, really important. I think time is a direct correlation. If you spend time with your patient, you know what their goals are, you know what their aesthetic is, you're going to get a good result. But when you just churn people through and you say, great, 15 minutes, see you later, you're going to get kind of a boilerplate aesthetic. You're going to get whatever the surgeon thinks is best. That's the result you're going to get.
Absolutely. I've had women who have told me he didn't ask me. He just put in whatever size he thought I was going to would fit me. And I think there's there's like some older surgeons who kind of are that like, I've been doing this for so long. I know what would look good in there. And, this is what I'm going to put in there. And also like in Florida and in Miami, when the surgeons aren't really the ones doing the consultation, it's more like the people on the phone, and they're not meeting the surgeon until the day of the surgery, right before the surgery.
That still blows my mind. Maybe that's part of this Midwest thing. Like, that's not how I was raised. That's not how I was taught to take care of a patient. We all went to med school. We weren't taught that in med school. That's crazy. So for me, that's so important, to get to know your patient. And, I always tell my patients, I give them my cell phone number when I operate on them. And I'll say, if there's an issue or you have a question, I want to be the first person to know about it. And then once I operate on someone, that is such a special relationship that we enter in together. And that's my patient forever. Once we do that, we're kind of linked together forever. So
You're my patient forever.
Exactly. That's really a special relationship for me. And, maybe that has to do with how I was trained in med school and residency, or even how I was raised in the Midwest. So I think those are really, really special relationships. I don't take those lightly.
I love it. So let's talk about something I haven't talked about on the show. And I think this is a perfect opportunity to talk about it. Two things. The first one is different incision placements. So I'm sure our listeners have heard of implants going in through the underarm, implants going in through nipples, implants going in through the folds, the inframammary fold, implants being put in through their belly button, all types of things. So I have my preferred. Y'all can't convince me any other way. And I really want to hear your take on the different incisions.
Yeah, I love this conversation. This is such a great discussion. And I think there's a couple of appropriate answers, and there's a couple of answers that I very much do not like. And then, of course, I have my preferred as well. So let's start with what not to do, I think. So I think the two worst incision types that I would never, ever do for my patient or consider for any of my patients are through the armpit or through the belly button. Those are two huge no-nos for me. That being said, a caveat is there are surgeons that do that and get reasonable results and they have happy patients. I'm saying for me in my practice with my patients, I would never put an implant in the armpit or through the belly button. And there's a couple of reasons. So in order to get the implant in there, you have to make a tunnel. You have to make a track through the tissue. So, in the armpit, you're all the way over in here, and you have to make a tunnel that goes all the way through the armpit and into the breast. You have to build that pocket, which is a very customized pocket for your implant. And then you put the implant in there, and the implant is going to go through the path of least resistance, which is through the tunnel that you just made. So more times than not, that implant is going to push back out into the armpit. And that's like the worst place that an implant can go. And we all know that. I mean, we've all seen someone or known a family member or friend with implants that are way out here in their armpit. And it looks terrible. The patients don't like them. You lay down on a bed flat and your implants go out on the side of your chest. Usually patients want implants on the front, not the back. So anyways, so that's why. Another reason is 99% of my practice are silicone gel implants. I love silicone gel implants. They're so safe. They're the best technology they've ever been. Every year they get better. You can't put a silicone implant in through the armpit, or it's very, very difficult to do that if someone's doing it out there. But classically, those are saline implants through the armpit. And same for the belly button as well. So to do that, you have to do a tunnel, a track that goes from the belly button all the way up. And with that technique, you also injure the inframammary fold, which is, some would say, the most important structure in breast anatomy. That structure allows the implant to sit in the right place and keeps the implant from migrating down, which is another terrible place for an implant to go. So both of those techniques, the armpit and the belly button, are huge no-nos in my practice. And then the other two big sites are around the areola, on the underside of the areola, and in the fold of the breast as well. So I'll go out on a limb here and say, personally, my favorite is the fold, and I talk about this a lot on my own social media and things like that. And I have lots of educational videos about this. That's my favorite incision for a couple different reasons. So one, it allows me the most control over the pocket and implant placement, very precise pocket and implant placement. It also stays away from the nerves of the breast and allows the patient to breastfeed later on in life if they want to do that. If it's a young lady and maybe they haven't nursed yet and that's something they want to do later in life, that preserves the ability to do that. So that's why that's my most important, my favorite incision. On the underside of the areola is a great way to hide the incision, but it can damage the milk ducts and also messes with the sensation to the nipple and areola complex a little bit more. So not an absolute no-no, but some ladies don't want that. They want to maintain the sensation to their nipple and areola complex, as well as maintain the ability to breastfeed.
Absolutely. So let me tell you my favorite and why. So
Yeah.
I've seen, my favorite is also the fold. And the reason why is because I was a patient coordinator for a long time, and we would have patients coming in from other surgeons who had different incision types. And one of the things that I saw multiple times was in like incisions from the underarm where the implants aren't even on the same plane. Like one's underneath the muscle, one's over the muscle.
Oh my God. Isn't that wild? Like what comes,
Wild.
like who's doing these surgeries?
Exactly. So,
What's happening?
and I've learned with experience from all of the surgeons that I've worked with, along with the surgeons that I've interviewed, that the inframammary fold is what they call the cleanest way to come in and do the implants. Specifically because you can see exactly what you're doing. You aren't guessing for anything. And with the areola complex, I've seen where the scarring isn't that great. So it is a lot more noticeable than if you did have that fold incision where once your implants drop, the incision's hidden. You can't really see it unless you're on your head, which
Exactly. Yeah.
just put a little makeup on it.
No, I totally agree with you. If done correctly, and if it's placed, in the perfect spot, once the implant settles, it's beautiful. It's like shaded. The shadowing in the fold of the breast is perfect. And honestly, like I'll tell you, like from my residency and fellowship, I was doing 4, 5, 6 centimeter incisions. Now I'm doing 3.5 centimeter incisions. So like the better you get, and the more skilled and experience you have, I'm doing 3.5 centimeter incisions now. Sometimes if a smaller implant, maybe even a little bit less, like closer to 3 centimeters, which is really hard to do. It takes a little bit extra time. But I think, that extra 1.5 centimeters, the patients love having a tiny little scar down there. So
Tiny
it's
little
worth an extra struggle.
Also, but I think we should also point out that if you're choosing a lot bigger, wider implant, your incision is going to be a little bit bigger and a little bit wider.
Exactly. So so when I put in those tiny implants, I did like a 175 or 195 a couple of days ago and got it to just under 3.5 centimeters. Felt good about that.
Happy. I bet she's so happy. She's like,
Yeah.
"Where's my incision? This one, I can't see it."
And then doesn't mess with nipple sensation, doesn't mess with ability to breastfeed. And also we didn't touch on the decreased rate of infections too, because there's bacteria that go through the ducts of the breast. And so if you stay away from that area, you decrease your chances for infection, which also decreases your chance for capsular contraction, which has huge ramifications years later on in your life. So another reason that the fold is best.
So you heard it here, you guys. I wanted to talk to y'all about it. This is the perfect chance to talk about it. If you're looking for a breast augmentation and you're like hearing different opinions, you're on the Facebook groups and this girl over here you can't even see her scar because it's in her underarm, or this girl over here, like her
Not
scar
worth it.
is in her belly button. This is the real, okay? Let's talk. We're talking about the real ramifications of having those types of procedures.
And all of the points that we made are all backed by years and years of data and studies. Like this is not just anecdotal evidence. This is hard data. So
yeah, thanks for bringing that up. That's a good point.
It's important. It's important.
So with the new technologies with implants, I think one of the things that always comes up in any conversation that I have with women about implants, especially if they're online, is what about breast implant illness and how like that's the main fear that they have. Like, what about breast implant illness? So I've had surgeons on the show who have talked about breast implant illness, and they've talked about the studies, and they've talked about the capsulectomies. So if you want to hear specifically just about breast implant illness, I have an episode for you about that. But on today, we can still talk about it, and I'd love to hear what your take is on it.
Absolutely. So I think that breast implant illness is something we still need a lot of research on. And I don't think that it's fair that surgeons dismiss it. And I don't think it's fair when surgeons jump all in and say, implants are terrible and you should never get an implant. So I think we need so much more research. And the American Society of Plastic Surgeons is dumping, the Plastic Surgery Research Foundation, we're dumping millions and millions of dollars into this, rightfully so, because we don't have enough information. We don't have enough data on this. I've treated patients where we've done en bloc capsulectomy, we've taken the implants out, and they get better. And I've treated patients where we do the same treatment and they don't get better. And so I think it's a personal journey, and you have to listen to your patient. If your patient is saying, I have symptoms X, Y, Z, and I need help, of course you're going to help them. I mean, you should. I will. I would. And so you got to listen to your patient, and you have to give them basically the entire landscape. Say, this is the information we have. This is the data we have, which is not much. We don't have a lot of objective markers. I would send them to see a rheumatologist as well. I would get some kind of anti-inflammatory, some autoimmune disease, like a workup with the rheumatologist. Make sure they're very well informed. See them multiple times for a visit, not just one consultation. See them multiple times. Lay it all out there. These are all the things we can do for you. We can take your implants out. We can take the capsule out. We can do it en bloc if you want. You're going to have drains. We can do a lift or no lift if you want. Really give them every option. Make sure they know each option and they know the risks and benefits for each option. And then ask them what they want to do. Let them think on it. They need time to think about this. It's a huge decision. And then tell them this could help you. This treatment plan could help you, or it could not help you, and you could still have the same symptoms. So I think it's a personal journey. And it's our job as plastic surgeons to give them all the information. We work for them. I work for my patients. And so once they have all the information, I am happy to make that happen.
Absolutely. I love that approach. I love that. Chef's kiss, because I can't tell you how many women I've met who have had breast implants for 20 years and have absolutely no issues. And I've met people who get in breast implants and they have symptoms that they're like, I didn't have this before. They take out the implants, but they still have the symptoms, or they don't take out the implants and the symptoms go away. But because there is so much controversy online about breast implant illness, there's this fear of, it's my implants. It has to be my implants. When a lot of times it could be something different, like an autoimmune disorder or different things that happen to women.
You're totally correct. So that's why I said it's unfair to make blanket statements and blanket judgments, because we don't have data. We don't have enough objective data to make blanket statements. So that's why I always refer back to the statement of, this is a very personal journey. So whatever is going to help you, whatever you think is going to help you, if you make an educated, informed decision, I will support you every time. And like I said, I've had patients who've been successful in their journey for explantation and not been successful in their journey with explantation. So it's a very personal journey.
Very personal. So that's I think that I'm glad we talked about it. I'm glad it's out there. I always want to be very honest with my listeners and with my girls who are considering these procedures. Some patients have no issues. Other patients have symptoms. There's no real concrete evidence of this is what's causing it. And until we have the data that shows which I think there is studies going in progress right now where we're going to have some information, some good data soon. It's in the works.
Yeah, it's in process. It takes time. Unfortunately, all this stuff takes time. And when the ASPS and ASF release all this stuff, then we say, well, we need more time. We need more data. There's always more and more. So we are aggregating as much data as possible. It's all in the works, and I'm excited to see what it is. So I think there's too many people on both sides of the fence to just say to dismiss anything. So you can never dismiss what a patient is coming to and they're saying, I have these problems. You can't dismiss that. So
yeah, for sure. So let's talk about this next thing, which is, okay, a patient is coming to you and she's like, I want more volume, but I don't want implants because I'm scared of BII. So what are their options?
That's a great question. So I have a little algorithm in my head about that because, there are patients who maybe just don't want an implant for whatever reason. They're maybe a little older, they don't want to deal with it, or for whatever reason, they don't want an implant. So I go through an algorithm in my head and I say, first, do they need a lift or not? Do they have too much skin? How is the placement of their nipple areola complex? Do they need everything lifted, or is everything in place and they just need volume? If everything is in place and they just want volume, fat grafting is one of the best things you can do. So I would say that's kind of the tier one to that. Next, if they need a lift, is how much volume do they already have? Do they have no breast volume and need a lift? In that case, that's a whole different category. Or if they have a reasonable amount of volume and they need a lift. So that's one of my favorite patients, when they have a good amount of volume and need the extra skin removed and need the nipple areola complex lifted. That patient, I do an awesome auto augmentation technique. And so I use the volume that you have and I rearrange it to give you a nice lifted breast, no extra skin, some upper pole fullness as well, using your own natural tissue. And that's one of my favorite cases to do. I really, really love it.
I'm so glad you talked about auto aug because I've had listeners who have recently been sending messages. Can you talk about auto aug? What is auto aug? So I'm so glad you touched on that.
Yeah, let's talk about that. So I have two different techniques that I use, and those are based on the patient demographic. So the first one is my weight loss demographic, my weight loss patient. So classically, the weight loss breast, and when I say weight loss, I mean like massive weight loss, like 50, 100, 150 pounds, something like that. So classically, that patient is left with no breast volume at all, lots of skin, and a low nipple areola complex. So that patient has no volume and all the skin and needs a lift and volume. And so how do you give that patient a lift and volume at the same time? My mentor, my breast surgery mentor, Dr. Renato Saltz, has this amazing analogy where he talks about the breast as a pillow and a pillowcase. The breast tissue is like the pillow and the skin is like the pillowcase. So if you have a tiny little pillow and a king size pillowcase, that's kind of the massive weight loss patient. You have no breast volume and you have a humongous pillowcase. And so what my job is as a surgeon is to match the pillow and the pillowcase. And so you get great volume and a nice, like, tight contour of the skin. That's my favorite breast analogy. Thanks, Dr. Saltz. So that's kind of the first patient. In that massive weight loss patient, Dr. Rubin created this awesome auto augmentation technique. The paper is from like 2006, I think, where he takes all that extra skin and uses it as volume and lifts it up on the chest like an implant. So no implant involved. but uses all that extra skin that classically in a breast lift, you would kind of just toss away. So that's a really, really great technique for my weight loss patients, massive weight loss patients. The second technique was created by Dennis Hammond, and it's called the lower island flap transposition. So this is for a patient who has a reasonable amount of volume, but has too much skin and the nipple areola complex needs to be lifted. So what this does is take the extra tissue that's in the lower pole of the breast. And what is the lower pole of the breast? It's from the nipple areola complex to the breast fold. So as we age, as you know, everything goes toward the ground. And so usually ladies' breasts, that lower pole is kind of bottomed out. And so if you have any amount of volume at all, it's usually in that lower pole, and then your upper pole is hollow. And the upper pole is from the nipple areola complex up to the breastbone or clavicle. So what I do is take that lower pole tissue and rearrange it and use that kind of as an implant, and I tuck it up under the nipple areola complex, and it really gives you a good amount of upper pole fullness, as much as you can get without an implant. And then, of course, the breast is lifted, the nipple areola complex is lifted, take off all that extra skin, and looks really, really nice.
I love that. Thank you so much for explaining that to our listeners and to me.
That was a lot of information all at once.
We love it, though. They love learning. They love hearing about all of these different techniques. And especially my listeners, sometimes they have questions for themselves, but also they have questions for their friends, and they have maybe them and their friends are talking about surgery, and what we're talking about today is something that is useful for them or their friends and family. So specifically for the weight loss community, because I know I have a lot of listeners who are in the weight loss community. One of the things that happens that I don't think we talk about enough is pseudotosis. So for the weight loss community, specifically after they lose a lot of weight, you lose some of that bounce and collagen and elastin in your skin. So even after you can get a breast augmentation, and I've seen this happen tons of times where they'll have a breast augmentation or a breast lift with an implant, and 6 months, a year, their breasts are lower, maybe not as low as where they started, but lower on their chest. And it's considered pseudotosis. So let's talk about that a little bit.
That's a really good point, because that's classically a mistake by the surgeon. So I'm not trying to
talk crap,
but so let's talk about pseudotosis and what pseudotosis is too. So pseudotosis is defined as your nipple areola complex is technically in an okay position, which means the nipple areola complex is above the fold of the breast. However, the lower pole of the breast is kind of bottomed out. Like you have a lot of tissue in the lower pole of your breast. So that's between the nipple areola complex and the breast fold. So the nipple is in the right spot, but the lower pole is not in the right spot. So for this patient, every patient's unique and every patient's different. But usually what I would do is a breast lift with this auto augmentation technique. So I take all that tissue that's in the lower pole of the breast and I move it to the upper pole of the breast. And you don't necessarily need an implant as long as the patient's as long as the patient's aesthetic goals and size goals are reasonable. So that's just using the tissue that they have and lifting that and giving a better arrangement of tissue instead of that bottomed out lower pole. You put that volume in the upper pole, which is aesthetically pleasing. So that is the first thing I'll say. I'll say, do you like your volume? Because I'll just redistribute the volume. And if you want more volume, I can always add an implant to that, of course. But most patients just say, yeah, I like my volume. I want it to be in a better distribution.
Yeah, they'll say, I like the volume, but I want them higher. I want them lifted where they used to be when I was in my teenage and early 20s.
Exactly. So a cardinal mistake, maybe for some surgeons, they'll say, someone comes in and they say that exactly. And they say, oh, I need an implant to do that. And sometimes the surgeon will be like, yeah, okay, breast aug, done. But that's not what the patient, they don't quite understand kind of how to make that happen. And they think, oh, an implant will fix that. Like, that's an easy fix. But it's not an easy fix. It's not an easy fix. They just need redistribution of what they already have. Which leads me to another thing, another problem that I see. So sometimes patients come into me and they say, I have this extra skin, put an implant in to lift me. Whoa, 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 whoa. Stop. Time out. Implants do not lift. So if you need a lift, you need a lift. If you want more volume, an implant solves a volume problem and an upper pole volume problem. But an implant does not solve needing a lift. And that's a huge kind of miscommunication sometimes between patients and surgeons. So
I totally agree. I actually talked about this recently on an episode where I had a woman who came to me who needed my help, and she had a breast augmentation. And I preach on this show, you guys will never get me off my soapbox about the difference between a board certified plastic surgeon and a cosmetic surgeon, and the nuances that as patients you don't understand the background and what they know. So this patient, she had gone to a cosmetic surgeon and he put in an implant, and she had the double bubble. So she had her implant up here and her breast tissue down here. And he told her that it was, that was just the way her body healed. And me knowing what I know, I'm like, it's because you need a lift. And he didn't recommend a lift because he doesn't know how to do them or he's not good at them.
Yep. I don't know what else to say except you're right. Like, yeah, it matters who you see. And I think, when you're going through training, residency, and fellowship, and you train with all these awesome plastic surgeons, and they make it look easy, and you're like a resident and a fellow, and you're like, oh my God, these guys are so good. They make it look so easy. And yeah, when you're good, you make it look easy, but it's not easy. These concepts are complicated, and you have to know when to use each tool in your toolbox. And you have to have the toolbox to use the tools. So
exactly.
A lot of, maybe some people don't. So
exactly. I have just enjoyed so much having you on the show today, Dr. Anderson. It was such a pleasure chatting with you and getting to hear all of your insights. So if one of my girls wants to come see you for that Midwest aesthetic, how can they find you?
Yeah, so I'm on Instagram. I'm Dr. Eric W. Anderson. And I'm pretty active there. I love to educate. I'm a dad, so I always have posts about my kids and how silly and crazy my kids are. I love to educate. I'm super approachable. We're in the Midwest, Chicago. Who doesn't want to come to Chicago in the summer? But yeah, and our website is impressionchicago.com. I'm partners with 2 facial plastic surgeons who are world-renowned and incredible surgeons. These guys are the best.
I love it. Thank you so much for being on the show. And with that, you guys, I'll see y'all next week.
Thank you so much.
Thinking about plastic surgery, but you don't know where to start? I've got you. With 18 years in the industry and experience working with top board certified plastic surgeons, I help women like you make informed and confident decisions. Whether you need help choosing a surgeon, planning your recovery, or understanding what to expect, I've got your back. Skip the guesswork and get expert guidance by booking a call with me today. That's a wrap for this episode of Big Butts No Lies. If you found this episode helpful, do me a favor and subscribe, leave a review, and share it with a friend who's considering plastic surgery. Your support helps more people get real, unbiased info they need. And if you're ready to take the next step in your surgery journey, I've got you covered. Book a consultation with me at bigbuttsnolies.com and let's create a plan to get you the results you've been dreaming of. Follow me on Instagram at Big Butts No Lies Podcast, on TikTok and on YouTube for exclusive behind the scenes and more real talk about plastic surgery. Until next time, stay confident, stay informed, and remember, big butts don't lie.